Thank you, Dave, and thank you very much. Good evening, everybody. It's a real pleasure to be here. I know that those of you who are at the LPC meeting today have had a long, hard day, which culminated in an extremely lengthy and difficult last session where I was talking about community pharmacy funding predominantly, and we got so stuck into community pharmacy funding, or I did, because once I get going I can't stop, that we didn't really have too much time to talk about what I really wanted to highlight now, which is where community pharmacy is going and really what the changes in commissioning moving forward and the general change in what people want to get from community pharmacy means for all of us in the future. And I think I've been kicking around pharmacy now for 20 years. I'm not a pharmacist, as I think most of you will know, but I do not think there has ever been a time since I've been involved in pharmacy where there has been so much appetite for really harnessing the power and the value that community pharmacy can bring to the NHS. And a number of things are contributing to that. First of all, of course, the massive financial crisis that we're in, which means that we simply do not have the resources to be able to afford not to use the skills that you can get in the community pharmacy. Secondly, the real focus of this government, and other governments have tried it, but this government really is serious about public health and about investing to prevent the massive surge of avoidable disease that is coming down the line as we all have too many chocolate mousse desserts. Some of us couldn't resist, and lucky Louise doesn't like dark chocolate, and unlucky me does. But, you know, we have got this tremendous surge of demand coming down. We've got medication that's keeping people alive for longer, but we've also got forces that are making people iller and more needy, and you all know much better than I do about the burden of diabetes and cardiovascular problems that are threatening to engulf the resources we're going to have available for the NHS. So that has created a great opportunity for community pharmacy. But the other thing, I think, which is really important, is there's this recognition that the vast majority of people who are ill are treated with medication, and that effective use of medication can be good, and ineffective use of medication can simply be a waste of money. And that is where I think we have a tremendous opportunity. So Pam talked about public health and the healthy living pharmacies. I think it's absolutely great that there's an interest in going forward with the healthy living pharmacy model here, and we know that the Minister, Earl Howe, was really impressed with what he saw down in Portsmouth and said, I just need to know that this can roll out in other parts of the country to Portsmouth, and we're going to prove that it can, and that using pharmacies in that way can allow us to get to whole cohorts of our populations who we will not reach in other ways, and the really energised, effective, skilled pharmacy team can deliver really good results and outcomes in an area which we do need to deal with. But the other area, and Jeanette used the term medicines optimisation in her talk this afternoon, but the medicines optimisation space is there for pharmacy. It plays exactly to the core strengths that you will get when you go to pharmacy school and learn about the medication, but it also is meeting this tremendous problem we have got about ineffectively used medications. Whether it's 50% of people who don't use medicines exactly as intended, 30% of people we know just stop taking some medication after a period of time. We know that we've got something like 6, 7, 8, depending on the statistics you use, % of hospital admissions directly related to ineffective medicines taking. That all represents tremendous lost opportunity or wasted costs. And I know, certainly I've come across in my life, people who have been collecting prescriptions month after month after month because they don't want to tell their GP they're not taking it, but they're not taking the medicine, or they're taking it only occasionally. And of course, general practitioners will make decisions quite often predicated on the fact that the medicines they're prescribing are being taken. So you have, I know we've got one GP here who probably doesn't, but we do know that in a lot of areas, medicine is systematised, and if something isn't working, you add something else in and you change. It might be quite unnecessary if the problem really is adherence. So we have this massive opportunity, I think, to show what pharmacy can do, to bring real benefits from their interventions, your interventions with patients. Which brings me on to what we are doing. As you know, we've been doing medicines use reviews for 6 years now, and we are moving to what to my mind is the next iteration of that, and that's to have those medicines use reviews targeted to where they can become most effective. One of the areas is respiratory, and in the area down on the south coast, there was a big study done of respiratory MURs and a focus on some local enhanced service MURs commissioned to supplement the national advanced service. And the result of that focus was a 50% drop in admissions to hospital from respiratory problems. 50% drop. And that actually translates into real cost savings. And the cost savings of that far, far, far exceeded the actual costs of the MURs themselves. Each hospital admission, I think the figure was about £1,500, is the figure for the hospital admission that always had an overnight stay, and yet you are looking at relatively minor spend to ensure that respiratory patients get a good intervention from the pharmacist. So that is brilliant. The other area I think is absolutely essential for us to try and deal with is the discharge MURs. Now they are going to mean some work, some communications between hospital and the community pharmacy, but the readmission rate of people whose medication regimes don't get sorted when they come out of hospital is very high, and again it's something that community pharmacy can really help to do, just to rationalise the medication, to make sure that when the patient's had a medication change that they get the right balance of medication and the right prescribing going forward. So that stuff is great. But best of all, and the jewel in the crown I think for us now, is the new medicine service. It launched on the 1st of October. It is rolling out across the country. Pharmacists who've begun to provide the service are finding that it works for them. Patients like it. We're not having difficulties enrolling patients to have the follow-on interventions. On the pharma-based module, which you will know we launched to support delivery of that service, in week 2 we were running at over 800 enrolments just on pharma-based alone by week 2. So we're getting a tremendous roll through, and that to me as the negotiator for pharmacy is really important, because if we can show not just that we can deliver the service, but we will deliver the service to quality and to scale and deliver the outcomes, then I think we really do occupy this vital territory of medicines optimisation. And that, I think, for all of us means that we've secured a role in really helping our patients in a systematised way. Through PharmaBase, unashamed plug for PharmaBase here, we are able to capture the outcomes, prove the value of what pharmacy does. And it's not been something pharmacists have been good at. We have been absolutely rotten at documenting and proving the value of the services we provide. So we deal with that one, and we make pharmacy easy to commission, to provide services, because the commissioners can get the feedback and the data that they need to support their commissioning decisions. So that is really important. I mentioned the tremendous funding pressures the NHS is suffering, and we also are going to face within pharmacy some new commissioning routes. And Pam has talked about public health. I've talked about the medicines optimisation space. The other thing, though, that I would say to pharmacists, and it's reiterating something I said very briefly at the end of my talk today, is that the new role that health and wellbeing boards are going to have for public health, and the engagement, therefore, that we can have as representatives of community pharmacy with local authorities, I think opens up a whole new opportunity for dialogue with them to start to see what pharmacies can do to work closely with local authorities to help them in other areas. And the area I was talking about this afternoon is social care. And for me, a lot of what community pharmacies do is social care. And pharmacies can do a tremendous amount to help people live independently, to help them manage their medication needs independently. And I think there is a tremendous opportunity now for pharmacy to really start to think about how it can work with local authorities, to partner with other parts of the whole social care systems locally to ensure that they contribute something, whether it's to ensure that patients who are living at home get monitored dosage services or medication reminder services, automated messages and telephone calls, checkups, whether it's supporting services around medication for mental health patients and things where there's a social care, but also working with mental health outreach teams. I think there is just a whole area where pharmacy can really start to think more holistically, if you like, about what it can do to help the communities and help the community social needs to operate effectively. So really, I wanted to just set up my sort of views about where I think we are going as a sector. I do think it's tremendously exciting, and I do think that we will find, when we look back, that this last few years and the next few years are going to be a real pivot point where, if community pharmacy gets it right, we have really added a tremendous value, and we have integrated pharmacy in a way pharmacy has never been integrated before into the whole fabric of our health and social care network. And that, I think, is something that didn't need to happen before, but my goodness me, it needs to happen now. And I really think we're on the way to getting that to happen. So that's all I wanted to say by way of introduction. And then we were going to have a Q&A session, which can cover, I think, Dave, more or less anything, provided it's vaguely polite. And Pam was going to join us. So